A proper deadlift is the result of a person's ability to move in and out of desired ranges of motions. Now, their biomechanics and structure are what allow them to do that. Conversely, when the biomechanics based off the structure aren't there and they challenge the deadlift, that's when we start to see people squatting their deadlift. So instead of this nice horizontal trajectory, we get verticality. What do we do about this? Is it good? Is it bad? Well, ultimately, it depends on your goal, but generally speaking, squats and deadlifts are apples to oranges. They're totally two different movement patterns. So we want to make sure patients can move horizontally and not squat their deadlifts. So in this video, I want to discuss why this happens, what the true source of the problem is, and then how can we continue to deadlift but still respect their structure and biomechanics so they're not compensating through it. Before we break down why this happens, we need to understand when this happens. That way, when it actually happens, we recognize and have the awareness to know, A, it's happening, and B, what are we then going to do about it? So it's actually pretty simple. What you're going to see when someone is squatting their deadlift are two distinct phases. There's going to be a knee phase and a hip phase, and this is on the way up and down. So you'll see the hip move for a given period of time, and then you'll see the knee move. Now, what we really should see during a deadlift is one motion. This is only a horizontal trajectory through the hips. There's very minimal knee bend during a proper deadlift. So when you are watching your patients or clients go through a deadlift, ask yourself, are you seeing two motions or one? If you're seeing two, chances are they are squatting their deadlift. So we know what to look for, but now let's understand why this happens. If your patient or client is squatting their deadlift, chances are they're going to have a pelvis that is more biased towards external rotation. Now, this isn't good or bad. This just makes them better squatters. Why? Because when we are in external rotation, think of it like a locked door. So people become more locked here. The muscles become more concentrically tight. And that is going to hold them in a position that looks like this. It's going to close the backside and it's going to open the front side. The result trajectory of this is vertical. Because when they try to go in a horizontal direction, they are getting reoriented and pushed this way to go vertical because these muscles are too locked. Someone that has the ability to hinge and go through a proper deadlift is just the opposite. They are more open posteriorly and they are more closed in the front. And the result of this is internal rotation through the innominate bones, a slight anterior pelvic tilt, but from a trajectory standpoint, now they can actually move through that space. Because as they start their motion, unlike the squatters who get redirected, they have eccentric tissue, tissues that have the ability to expand. So that expansion allows them to continue in that trajectory. So when you are working with someone that squats their deadlift, we need to start thinking, are they too concentrically biased here? And if so, here's a framework that you want to start thinking to truly get after the source of the problem. So to address the source of the problem, we need to go back to the root cause of it. We talked about how someone that has a hard time to hinge is too locked here. So a great framework is finding ways that expand here, but also give a little bit of rotation because then it's going to pull and expand even more. So a great exercise is throwing the leg up, working on eccentrically orienting all the external rotators, the piriformis, the glutes, and then we just work on turning our pocket. Now, like I said, this is a great way to start to fix the source of the problem. But this video is actually not about the source of the problem. It's about how do we continue to deadlift but also respecting the biomechanics of the patient. So we can do this by elevating three different things. When we elevate these components, we start to push them towards the opposite pattern. Remember, they're here. We're going to start to try to bias them here. The deadlift requires that, so we are going to use 3 different strategies, elevation strategies, to start to drive the proper biomechanics. The first elevation is going to be the toes on a slant board. When we go into a toes elevated position, it actually pushes us back. Because we get pushed back, we have a response of a slight anterior pelvic tilt. Nothing huge, but a slight anterior pelvic tilt. What does this do? It shifts our center of mass forward. What it also does is it internally rotates the pelvis and it pronates the feet. Internal rotation is going to create space posteriorly. So we are starting to elongate the tissues posteriorly. Remember, we need that for a proper deadlift. So elevating the toes and then going through our deadlift is a great way to start to bias the right biomechanics and have the outcome you're looking for. The next thing we're elevating is the floor with a riser or anything that you have access to. When we raise the floor up, we help patients that don't have that range of motion. Now, we're still elevating the toes, so we're biasing from that standpoint, but now we're going up to meet them where it's best for their structure. So a lot of people squat because as they go down, they hit that constraint and then they start to move vertical. We need to raise the floor before they hit that constraint. So we have a riser here. You might need 2, you might need 3, you might need 4. The key here is that when we're going through the motion, that the person is really truly hinging, and the point that they want to start to flex the knees, that's where we need to raise the ground to. So as we go through it, it's still our normal form. We just are hinging and deadlifting from a raised platform. The last thing we can elevate are our coaching cues. We have to be really good with the words, the language, the cues that we use for our patients so that we drive the right movement. A lot of times we subconsciously say things that actually tells them to squat, like squat down to the bar or go down to the bar and grab it. So we need to get really intentional with the cues that we use. Here are some things we can think about. When we're in this position, I like to tell people, imagine you have grocery bags in both hands, but you need to close the car door. How do you do it? Everyone, even if they don't know how to deadlift, immediately goes into a hinge motion. Great, use that cue. Another thing we can tell them is that they must feel their hamstrings. So if they go down a couple times and they bend their knees, they're not going to feel the hamstrings. If they do that, we can go here and tell them, straighten those knees slightly. Feel your hamstrings start to turn on. The hamstrings are just a reference point for them to know I'm not bending my knees, aka I'm not squatting the deadlift. So those are 2 cues that we can really use to drive the right mechanics while also minimizing the confusion. Remember, cues should always minimize confusion and maximize clarity.